are measuring total serum immunoglobulin. انتوا شفتوا يعني بالCVID total serum immunoglobulin is quite low. We measure a specific antibody response against Haemophilus influenzae, Streptococcus pneumoniae, if low. If low, this specific antibody, you have to vaccinate such patient by killed vaccine. Do you give attenuated or live vaccine? Of course not, because these patients are immunocompromised, immunodeficient. Only vaccines that can be used are the killed vaccine. So you give vaccines and you can measure the response after 6 to 8 weeks. You can do protein and urine electrophoresis to see whether the patient secrete or expel some of this immunoglobulin or protein through the kidney due to certain defective conditions. Flow cytometry to quantitate B cell and T cell number and their subtypes. This is the flow cytometry. هذا الجهاز اسمه flow cytometer. You put your sample here and it will quantitate to you the B cells and their subtypes in a graph like that. So we can know the type of T cell. For example, T helper or T cytotoxic. T helper, their subtypes, whether they are Th1, Th2, Th17, etc. T9. Management of a primary immunoglobulin, therapeutic and prophylactic antibiotics, azithromycin, thrice weekly, every other day. The mainstay of a treatment to give intravenous immunoglobulin in infusion every 3 to 4 weeks, or you can give it subcutaneously using a special pump every 2 weeks. فإذا intravenous every 3 to 4 weeks, subcutaneous every 2 weeks. Intravenous immunoglobulin and subcutaneous immunoglobulins are given in hospitals, day clinic, or the subcutaneous can be administered at home, because the patient will stay on these infusions for the rest of their life. فاللي يقدر ياخذ هذا, they insert the pump at night and then get next morning and the subcutaneous infusion is finished. We said we have a primary immune deficiency and secondary immune deficiency. Secondary antibody deficiency, secondary to other diseases, to other conditions, multiple myeloma, they lose a protein. That is why we do a checking electrophoresis for a protein in the urine. You know, Benz-Jones protein appear in the urine in multiple myeloma, chronic lymphocytic leukemia. And these patients are susceptible to bacterial infection like pneumonia. Patient with splenectomy or hyposplenism, these patients may have an acute life-threatening septicemia, because when the patient have hyposplenism or infarction in the spleen or splenectomy, they lose the splenic macrophages, which can secrete circulating microorganism, and also they produce inadequate amount of antibodies against polysaccharide, and these patients will suffer from microorganisms which have polysaccharide capsule, like Haemophilus influenzae, Neisseria meningitis, Streptococcus pneumoniae. So these patients have to be vaccinated by killed vaccine against this microorganism. Also, they should be put on a prophylactic penicillin V for the rest of their life. Now we come to T lymphocyte deficiency. primary TLD, primary T lymphocyte deficiency. These patients will suffer from not extracellular infection, but from intracellular or big organisms, from viral, protozoal, fungal. So if you see a patient with repeated viral infection, this may indicate to you that this patient suffers from primary T lymphocyte deficiency. Many of these deficiencies may be associated also with antibody deficiency, since T cells control B cells, as you know. So if the T cells is defected, of course the B cell will be defected. These patients with T cell dysfunction may result in reactivation of latent viral infection, like herpes simplex, cytomegalovirus, varicella zoster. These patients may suffer from mucocutaneous candidiasis and systemic fungal infection by Candida albicans or other fungi like Aspergillus or Cryptococcus. We mentioned Cryptococcus is important in immune deficient Pneumocystis jirovecca pneumonia, and we mentioned this. Mycobacterium tuberculosis and MAC, atypical ones, or protozoal infection caused by Toxoplasma and the Cryptosporidium. So let us take a few examples of the T cell lymphocyte deficiency. داي-جورج syndrome. هيك ملخص قبل ما أحكي عنه أي شيء. داي-جورج syndrome, there is no thymus. Absence of thymus. تعرفوا أنتوا دور الثايمس بالتي سيل بالتي cell maturation. Without thymus, there will be no T cells. This syndrome results from failure in development in the third and fourth pharyngeal pouches, from where the thymus arises together with other organs. And this is caused by deletion of a gene called 22q11.2 gene. Other organs may be involved, abnormalities in aortic arch, hypocalcemia, tracheoesophageal fistula is called TE fistula, TE fistula, a cleft lip and palate, الشفة المشقوقة, شوف شفة مشقوقة, cleft lip and palate, and then absence of the thymus. All of these have the same origin from the third and fourth pharyngeal pouches. You have to remember your embryology. It is characterized by very low number of mature T cells in spite of normal bone marrow. Bone marrow is normal, but there is no thymus here. A treatment to do transplantation by fetal thymus. Fetal thymus, a transplantation. The aborted fetus, they take the thymus from that fetus and transplant it. It is a successful operation. Again, the T cell function and the dysfunction, bone marrow stem cell. Here we have the severe combined immune deficiency and failure of thymic development here, no thymus, Dye-George syndrome, or the thymus does not express HLA molecules, and this will result in Berry lymphocyte syndrome. You know, the T cells are educated in the thymus to recognize self from non-self antigens via the HLA class 1 and class 2, which are expressed on the thymal cells. Again, you can go further step when the mature differentiated T lymphocyte goes to the secondary lymphoid organs, there may be failure in the cytokine production, and this is cytokine deficiency. So T lymphocyte activation and effector function will be affected due to failure in the cytokine production, failure in apoptosis, and this will result in autoimmune lymphoproliferative syndrome. You know, apoptosis is very important function in these T cells. So let us take a few examples and explain them. Severe combined immunodeficiency. شو معناته combined؟ يعني B cell and T cell. لأنه early in the lymphoid precursor. This is caused by defect early in the lymphoid precursor. So there will be a result in the failure of maturation of both B cell and T cells. This is a major defect of adaptive immunity. This will result in infection with all microbes, recurrent, bacterial, viral, fungal, extracellular, and intracellular. It is a very serious condition. The patient or the infant die very early in life if left without a treatment. Treatment is by bone marrow transplantation, and specific gene therapy has been tried recently and it is successful. And also you can give immunoglobulin and antibiotic, immunoglobulin replacement and antibiotic cover. Wiskott-Aldrich syndrome. So it is syndrome composed of a thrombocytopenia, eczema, infection by what? Ward by molluscum contagiosum, malignancy, B-cell lymphoma by EB virus, and neutropenia. So this Wiskott-Aldrich syndrome, they have got WAS, Wiskott-Aldrich syndrome protein gene defect. So this gene defect is X-linked disorder, XP1123. The patient usually have no family history. It's de novo maturation. يحصل هيك طبيعيا. What is the defect? Let me just review to you something that you had in your course of immunology. In normal individual, T cell activation occur via ZAP70, which activate T cell. ZAP70 is one of the molecules that activate T cells and WASP protein, forming synapses to deliver cytotoxic T lymphocyte perforin. You know, cytotoxic T lymphocyte produce perforin to kill target cells and the granzymes. These are the killer material of cytotoxic T lymphocyte. The defect in the T cells, in the B cells and dendritic cell, leading to impaired antibody production, mainly IgM. The treatment is to do stem cell transplantation. So you can see this patient have multiple face petechiae and hematoma, eczema of the foot. If you see these pictures, this is Wiskott-Aldrich syndrome. What is the treatment? A stem cell. The patient suffer from IgM deficiency. Berry syndrome, Berry lymphocyte syndrome, here there is a failure to express the HLA on the thymic cells. As you know, class number 1 act with CD8. Class number 2, HLA, act with CD4. So failure of HLA class 2 expression result in systemic vasculitis. This is due to uncontrolled NK cell activation. NK act in the absence of HLA cells instead of CD8 cells. يعني من تغيب ال CD8 عن الأكشن ال NK يتعوض ويحصل vasculitis. treatment is stem cell transplantation. You have to repeat some of your immunology items in order just to reactivate your memory. Another condition which is due to T cell deficiency, a chronic mucocutaneous candidiasis. This condition may occur with or without endocrinopathy, like hypoparathyroidism. This is inherited condition, autosomal recessive, in a chromosome 2 defect. So you have to remember the defects of the chromosome that I have enumerated to you. Okay? Repeat them. Affect both male and female. شو يحصل هون؟ التي سيل كلها شغالة. بقية الاميون سيستم كله شغال باستثناء التي سيلز المخصصة للكانديدا. هذه ما تشتغل. is present in the first year of age, but may be delayed to the second decade. The patient will suffer from candida infection of the skin and the mucous membrane. It is poorly defined. The defect in the specific T cells against candida. Patients have normal T cell-mediated immunity, normal antibody, normal T cells against all antigens except candida. So when you do candidine test, which is similar to tuberculin test, but here you use candida antigen, it is negative in spite of long infection. Management, topical and systemic antifungal, and you can use immunotherapy, a transfer factor, just to control the infection by candida. Investigation of a primary T cell deficiency, flow cytometer to know the total and subpopulation of the lymphocyte, functional test to see the activity of T cells. You test the patient for HIV. As you know, HIV infect T cells, CD4 cells. So every patient with defect in the T cells should be checked for HIV, and serum immunoglobulin measurement for associated antibody deficiency, since T cells control B cells. So if the T cells are defected, the B cells also will be defected. Summary of the management of the primary T cell lymphocyte deficiency: anti-pneumocystis, antifungal prophylaxis, aggressive antimicrobial therapy, immunoglobulin replacement, stem cell transplantation for Berry lymphocyte syndrome, thymic transplantation for Dye-George syndrome. This is a sort of summary to what I have said. Complement deficiency. I said every item of the immune system may suffer from immune deficiency. Complement deficiency, this is genetic deficiency of all complement protein are described. مو كلهم يجوا دفعة واحدة. Item, or more than one item. These patients are susceptible to capsulated microorganisms like Haemophilus influenzae, Neisseria meningitis, pneumococci. These patients also have a high prevalence of autoimmune diseases such as SLE. Investigation, you have to measure C3 and C4, complement 3 and complement 4 level in the serum. Also, you have to check the function of the classical complement pathway by classical hemolytic pathway 50CH50 ملخصة هذا classical hemolytic 50 is screening test for determine the function of the classical complement pathway. Also, we have alternative complement pathway 50 for the alternative complement pathway. Here you check the function of the classical and the alternative complement pathway. Management of the complement deficiency, prophylactic long-life penicillin, prevent meningococcal infection, vaccination against these important microorganisms which are capsulated, Neisseria meningitis, Streptococcus pneumoniae, and Haemophilus influenzae. Also, the patient may suffer from C1 inhibitor deficiency. And yesterday we have spoken about angioedema due to deficiency in C1 inhibitor. And the patient may suffer from hereditary angioedema. Now we go to the last items, the primary phagocyte deficiency. Primary phagocyte deficiency. These defects are represented by recurrent bacterial and fungal infection. Bilphagocytic and phagocytosis important for bacteria and fungi, so these will be presented with recurrent bacterial and fungal infection at unusual sites. Usually occurs at childhood and milder form in adulthood. We have three types of primary phagocytic deficiency. اللي تحاكي the function of the phagocytic cells. انتوا تعرفوا الphagocytic cells من يصير infection في area, it has to migrate to the area of infection. فتعمل attachment to the blood vessel and then migrate. يصير عندك defect in leukocyte adhesion. الديفكت الثاني يصير defect بالكيلينج بروسيس اللي هي الاوكسيداتيف killing inside the phagocytic cell. So you will have a chronic granulomatous disease. It's called CGD, very important disease. And lastly, defect in the cytokine and cytokine receptors. So let us talk about them. Leukocyte adhesion deficiency. This disorder, the phagocytic cell migration, cannot migrate because they cannot express the adhesion molecule on themselves and on the vascular endothelium. So the phagocytic cells cannot migrate to the area of infection. So if you have bacterial infection in area, the bacterial infection will be without pus because the neutrophil cannot migrate. And this is reflected by very high amount of these cells, like a neutrophil in the peripheral blood. There is a special test to detect the adhesion molecule, and these molecules reduced or absent on the neutrophils. CGD, there is failure in the oxidative killing of phagocytic cells due to mutation in the gene of NADPH. You know, NADPH is very important in the oxidative killing of the phagocytic cells. And this will lead to infection by fungi, bacteria, granuloma formation. انت من تفحص المريض تشوف جسمه مليان بالجرانيولوماز everywhere, in the lungs, in the lymph nodes, soft tissue, bone, skin, urinary tract. Many granulomas at these areas. The best test to see the activity of the phagocytic cells is to do MBT test. What is the MBT test? Tetrazolium reduction test, which measure the phagocytic activity. Remember, MBT, tetrazolium reduction test, which measure the phagocytic activity of phagocytic cells. The last defect in the phagocytic cells cannot produce cytokine or cannot express receptors for the cytokine. Deficiency in cytokine such as interferon gamma, interleukin 12, or their receptor result in failure of intracellular killing. This may lead in particular to susceptibility to infection by mycobacterium. How we detect defect in cytokine and cytokine receptor? By ELISA or PCR. Management of a primary phagocytic defect, intravenous antibiotic, aggressive treatment. You give good doses of antibiotic and antibiotic of the recent classes. Prophylactic cotrimoxazole and antifungal agent. Interferon gamma may be used. Surgical drainage of abscesses. Bone marrow transplantation is conducted in childhood. If not conducted in childhood, you cannot do it for adults or in adulthood. Gene therapy is under trial. Secondary phagocytic defect, as we said, for each item of primary and secondary. In neutropenia, neutropenia may result from bone marrow diseases such as leukemia, aplastic anemia, cytotoxic therapy, يقلل النيوتروفيلز. Abnormal phagocytic function in certain conditions, diabetes mellitus. Patients with diabetes mellitus have abnormal phagocytic function. That is why they get infection. Or chronic renal failure also. Alcoholic individuals may also get abnormal phagocytic functions. This is just for your information. ما داخله بالمحاضرة. The microorganisms that are common in each type of immune deficiency. Antibody deficiency, extracellular infection. Like what? These are the microorganisms. T lymphocyte, mycobacteria and viruses, protozoa. In complement, Neisseria, gonorrhea, Neisseria meningitis, Haemophilus, phagocytic cells, Staph aureus, Mycobacterium, atypical ones, Pseudomonas, Candida, fungi. Candida. This is just, you can read it just to support your background. Any question? By this, you finish all lectures for the course of internal medicine, and I hope to you all the best and success, inshallah, in the examination.